And we are live, Senators.
All right, good morning. It's April 19th. This is the Senate Health and Welfare Committee meeting, and we're starting out with H-171, an act relating to adult protective services. So we have more, we have our testimony lined up this morning. And I'm not sure how you want to go. Stuart, did you want to go first or last? Because I'll give you that option.
I'll go last.
All right,
Yeah.
okay.
Thank you.
All right, so why don't we start with Jamie Brew, a Senior Director of Nursing at the Howard Center, and thank you for being here.
Sure, thank you. All right, so thank you for having me. I submitted a written testimony last week.
Yep, I think we had.
And so what I wanted to spend my time on was, I'm happy to answer any questions about it, but I wanted to provide a few examples of real situations that we encounter in human services, caring for vulnerable adults with mental illness and developmental disabilities, and how we see the words negligent, the addition of that language to the definitions of abuse and neglect as impacting the work that we do and the clients that we serve. Understanding that we don't want to ever cause errors, regardless of the level of training that anyone has. We mostly hire lay people to provide care in our residential programs, and our clients who are served by their family members who are paid caregivers, our clients who have paid direct support professionals in the community settings, as well as our nurses and our psychiatrists at all levels of training. None of us want to make any errors, and we all want to hold each other accountable. But the concern is any sort of mistake, there's almost always multiple layers that led to that error occurring, that finally reached a patient or a client. So whether it was a drug that was prescribed incorrectly based on a client's or individual's weight, certain drugs are dosed based on weight. If the weight is entered incorrectly, the prescriber might order a prescription based on that weight, thinking that that's the correct weight. A pharmacy would dispense that drug and somebody would administer that drug. We can spend a lot of time trying to figure out, well, who do we blame for that? But that doesn't solve the problem of how did that mistake occur and how can we prevent that from occurring in the future? So in healthcare settings, as well as other settings, aviation is a big one. Many years ago now, the airline industry started implementing checklists because despite all the hours of training that pilots have, there were still mistakes that led to really serious harm. And so industry is another one. And so even in the operating room, if you're going in for a surgery on your right knee, you better believe somebody before you even went in that room marked your right knee to make sure somebody didn't do the left knee. If you have a situation where a mistake occurs and we report it to Adult Protective Services, we're gonna withdraw the care. We're gonna put somebody on administrative leave because we don't know if that case will be substantiated or not, which means that we may be increasing our staffing crisis. We're already in situations where we have minimum staffing available, and sometimes we're filling shifts at the last minute and we still have call outs and people are stressed. So somebody might be responsible for administering all the medications, but now they're also cooking dinner. And so they might forget the medication that was supposed to be administered with dinner time because they're trying to make sure everybody has eaten and cleaned up. If we punish that person, and it may not be intended to be a punishment, but if you're the person who was responsible, it will feel like a punishment to say you can't work because we had to report that mistake of that missed medication to Adult Protective Services. Yes, we might pay you for that time, but that's several days where it will be, where you'll be unavailable to provide supports while Adult Protective Services first reviews the case, then decides if they're going to investigate it, and then decides if it will be substantiated. And that would impact, again, our clients living with a shared living provider. When we make a report to Adult Protective Services, we'll remove a client from the home until we know it's safe for the client to be in that setting. If we have nurses in the hospital, I've worked in a hospital setting. typically, like I said, it's not just down to the person who gave the medication. There's a lot of events that occurred where a mistake hopefully can be caught. That's why we have checklists. That's why we use computerized systems. That's why when you go to even to the lab, before they actually put the label on the tube, they verified your name and your date of birth 16 times. And still had you look at it and maybe even scan the barcode on your wristband, because in the course of a day, we can all easily make a very simple mistake that can have catastrophic results. In Howard Center, as well as all the other DAs and SSAs in Vermont, again, I'm going to emphasize this, we are delegating our med administration and procedures to lay people. We are training them as fast and as best we can. But we're doing so under the authority and the responsibility of our license to say we can't have nurses in all care settings in the community. So we train them, we hold them accountable. Likewise, they are under the authority of our license to make sure that they are carrying out those orders correctly. If an error is and that's a scary thing, truthfully, as a nurse, to worry about how, if I have 100 different people I delegate in a year to administer meds, I really pray and hope that they're all going well, but I'm never going to know if there's an error unless people are going to report errors. And if there's a fear involved that they might get reported to Adult Protective Services, I wouldn't blame somebody, and I can imagine it would happen where you might say to your coworker, ask them to cover it, because if I can't work for the next 4 days, then this home can't operate. Or I'm afraid of what would happen to my reputation. I don't want people covering up mistakes. I don't want people to feel shame. I want them to understand what happened. I want to hold them accountable. If it was a reckless act where they knew what the risks were and they ignored them, we would report that to Adult Protective Services. We already do that. If we have blatant instructions and we've provided training, if we've reinforced that training, we've disciplined, and the errors still continue, or there's a severe consequence, we do already. That's not something that wouldn't happen if we didn't add that language.
I noticed in your written testimony, which we do have, it's now on our webpage, so if you refresh, look at it, that you have some recommendations at the end regarding negligently and negligent, and then keep retaining the words that you just said, purposefully, knowingly, recklessly. That
Yes.
concept, so.
Right. Right. If somebody can't get their outpatient ECT treatment,
Yeah.
they desperately need, but somebody forgot they had that scheduled and they accidentally gave them breakfast and now they can't get anesthesia and they can't get ECT. Nobody meant harm by that. They were trying to do right.
Right.
We need to improve the system of why did that person not realize that today was a day where they were not supposed to have anything to eat or drink.
Okay. Questions? Thank you. So, and thanks for being very explicit about your recommendations. That's extremely helpful. So I know this was an issue that's come into our committee, and so we'll be looking at that specifically.
Thank you.
Thank you. Thank you very much. Betty, is it Hassan or Hassan?
Yes, good morning. My name is Betsy Hassan.
I think we have guests with us first. Do we have guests
Yes.
with us? Would you like to introduce your guests? And
Yes,
then
thank you,
also
Madam
some of you
Chair.
Would like to introduce our guests?
I'm sorry, I'm late. I have Joanna Grossman with me from the Emerge Vermont program.
Perfect.
She's shadowing today.
And I have Nakuma Kessling. I wasn't even close. Thank you. Welcome.
We've met
Yes, we
before.
have. We spoke during the campaign.
That's right. It's good to see you. Thanks for being here, both of you. Great.
It's a
busy morning in
busier
here.
than
Yeah.
usual.
Yeah. I think we are absolutely at the limit. We might be one over, but we'll be okay for now.
I turned on the air.
Yeah, we got the air on. That's good.
will breathe.
Okay.
Everybody hold it. Don't faint, Mari.
So Betsy Hassan, thank you for being here. And I think we have something from you on our webpage. And so
Correct,
why
you're for
don't you
in testimony.
introduce yourself and go right ahead with your testimony.
Sure, good morning. So good morning, Chair Lyons and committee members. Thank you for the opportunity to testify today on behalf of the American Nurses Association Vermont. And today's testimony represents a broader coalition of healthcare professionals of trade associations representing hospitals, home health agencies, long-term care facilities, physicians, federally qualified health centers, and designated agencies. The American Nurses Association of Vermont is the professional organization representing 14,000 registered nurses in the state. I'm Betsy Hassan, and I'm on the board of directors for ANA Vermont, and I've been a registered nurse since 2009 and in Vermont since 2016. I've received my bachelor's and master's of science in nursing from the Johns Hopkins University School of Nursing and my doctorate of nursing practice from the MGH Institute of Health Professions. I hold specialty certification as a board certified nurse executive and a certified professional in patient safety. I've been a direct care nurse, a nurse educator, a program leader, an operational leader, and an executive. Today, and on behalf of my colleagues, I want to express genuine appreciation for our partners in adult protective services and the important role they play in ensuring Vermont's most vulnerable are safe. The American Nurses Association of Vermont strongly supports the need to report abuse and neglect of vulnerable adults, and nurses appreciate the importance of their role as mandatory reporters. However, there is genuine concern for the impact for every nurse and healthcare professional due to the language in H-171. The bill proposes to add the word negligent to the definitions of abuse and neglect. Today, I'm here to talk to you about the impact that will have on the culture of safety that the healthcare system has been striving for over 20 years. A culture of reported potential and real adverse events is a healthcare industry best practice established in the 2000 seminal report from the Institute of Medicine to Err is Human, Building a Safer Health System. It is an essential component of building a culture that does not demonize and punish healthcare workers for events created by a failing system. We want our staff to tell us the barriers in their work to patient safety. This seminal report was transformative for healthcare. As noted by Dr. Lucian Leap, who is a major contributor to the IOM report, he testified before Congress in 2000 to say, and I quote, "Approaches that focus on punishing individuals instead of changing systems provide strong incentives for people to only report those errors they cannot hide. Thus, a punitive approach shuts off the information that is needed to identify faulty systems and create safer ones. In a punitive system, no one learns from their mistakes. Cultures of blame make the entire health system unsafe. A just culture promotes psychological safety for healthcare workers to report their mistakes and potential errors into a system that provides expert review and analysis to determine the contributing factors to those mistakes. The improvement framework does not punish the individuals, but addresses the causes within the system that led to the actions of the error to make sure it does not happen again. This concept is widely accepted throughout the healthcare system. It's supported by the American Nurses Association, the American Medical Association, the National League of Nursing, the Institute for Safe Medication Practices, the Institute for Healthcare Improvement, the Agency for Healthcare Research and Quality, and the Joint Commission, to name a few. Creating environments where healthcare professionals do not fear retribution for disclosing their inadvertent and human errors, which are inevitable in everyone's daily work, is necessary to improve our healthcare delivery systems and make them safer. Healthcare organizations are required to have a quality assurance improvement program that enhances patient safety through the development of a just culture that requires input from all relevant staff to identify the system's issues that cause most adverse events. In addition to the extensive oversight of adverse events that include reporting serious adverse events to the Vermont Program for Quality in Healthcare, the rigorous and frequent federal regulatory reviews performed by licensed nurses on behalf of CMS, and for licensing matters, the expertise of the Board of Nursing and their knowledge of nursing practice and the provision of healthcare. The expansion of mandatory reporting to include negligence within the definitions of abuse and neglect, including the negligent failure or omission by a caregiver to carry out a plan of care, will adversely affect all nurses and healthcare providers. The definition of a vulnerable adult could encompass almost every adult in a care setting who is temporarily disabled and requires assistance with personal care, or who have some impairment in their ability to protect themselves from abuse or neglect. These expansive definitions will confront nurses in their everyday work as they assume the care of a patient from a coworker who may have missed a scheduled dose of medication, become aware of a patient fall or pressure injury, or missed a scheduled treatment. A direct care nurse nor a layperson investigator from Adult Protective Services have the ability to conduct a root cause analysis to determine if the missed dose or patient fall was the result of professional negligence that a reasonably prudent nurse could have avoided, or that it was caused by a flawed process, short staffing, or the needs of other patients. Nurses will only know that they have an obligation to report themselves or their coworkers' failure to follow a plan of care. A root cause analysis and an assessment of professional negligence takes time, longer than 2 business days, and requires transparency and expertise to determine if a reasonably prudent healthcare provider could or should have avoided the deviation from plan of care. And that analysis is further scrutinized by regulators. As an example, in my time as Chief Nursing Officer and Vice President of Patient Care Services of a Vermont community hospital, the Patient Safety Department received over 6,000 event reports annually. A significant portion of these could be attributed to omissions of medications or medication errors, patient falls, pressure injuries, or other inadvertent mistakes. Through event reporting and the root cause analysis, reports to APS are made when there is any reason to suspect deliberate or reckless behavior. Nurses and healthcare providers, when under investigation for potential or suspected abuse, are typically removed from care environment until the investigation is completed. With the expansion of abuse to include negligence, many of these 6,000 adverse events would be reported to APS for review, thus pointing the finger at the healthcare workers for failures in the system and removing them from the workforce until APS completes the investigation. Lowering the standard of abuse and neglect from a nurse that is acting with purpose, knowledge, and reckless behavior to a nurse that makes a mistake that could have many contributing factors not only adds fear, but will deter transparent reporting and degrade just culture. It will also overburden agencies who should focus on investigations of perpetrators who engage in purposeful and reckless abuse and of negligent, vulnerable adults in less regulated settings. The ANA Vermont urges the legislator to be cautious in considering the proposed expansion of abuse and neglect to include negligence, especially for highly regulated healthcare workers, where such a change could have significant systemic impacts on just culture, the healthcare workforce, employers, professionals, and patients. As professions that are guided by science and evidence, the evidence indicates that the proposed expansion in H171 would encourage a culture of blame and diminish patient safety. Thank you.
Thank you. And you also have made some very specific recommendations at the end of your testimony, which is very helpful for us as we go through the bill and consider. Questions committee. Thank you very much.
Thank you.
Terrific. Joe, you are not on my list, but you're here. And are you? Would you like to testify?
I would just take a moment. I know that Stuart is going to be making a proposal to further examine this language. So I'll defer to him because I know that that's coming, just in the interest of keeping things efficient today. But thank you for the opportunity.
All right, thank you. All right, so we'll move on to Ruby Baker. Welcome. Welcome back.
Thank you.
Hello, for the record, I am Ruby Baker, Executive Director of Community of Vermont Elders, otherwise known as COVE. And just a little bit of background, and I think you have my testimony. COVE was established a little over 40 years ago to be the voice of older adults. We operate independently in the state. We are not representing service providers. We are not representing state systems. We are a grassroots organization speaking on behalf of older adults here in Vermont. We are also the federally designated entity that handles cases of Medicare fraud. And our work goes beyond just Medicare fraud to support victims of crime who are older adults in many areas, including general scams and fraud, and helping with assistance to navigate the justice system. We employ the only victim advocate for older adults in the state of Vermont, and this person works closely with partners in state government, including APS, as well as many others across the state. We have a long history of advocating for vulnerable adults in the state of Vermont, and COVE, along with Vermont Legal Aid and Disability Rights Vermont and others, was part of the lawsuit brought against APS for failing to adequately protect vulnerable adults in 2011. Since that time, we've seen significant improvements. We've been involved actively in the APS Advisory Committee. We have conducted file reviews alongside our partners in state government. And the improvements both to that system and to the inclusion of stakeholders has been transformative, I think. And so we are very grateful for the opportunity to be involved in the process. And over the summer, we literally went with Stuart line by line through every single part of this bill. So the process has been incredibly inclusive. Cove's opinion is that H-171 represents significant improvements to the law. There have been changes to the current protective system, and we generally support the reform effort. This is a 50-year-old statute. It needs to be modernized. We have changed, specifically in the last 2 decades, really changed the way that Vermont invests in aging within our communities, and has made those investments to home and community-based services, to people living with their families, and less in institutional settings. So the bill 50 years ago was really set to address issues within institutional settings, and fewer people live in that way now. So we need to update the statute, and that's a lot of what this bill does. The bill creates an assessment track. That assessment track recognizes that many of the cases that come across the desk for APS need a social service lens rather than a punitive lens. These are situations that need to be improved and not necessarily a person who needs to be punished. There are also protections for alleged victims who now, if you pass this bill, would have rights. And under the current law, victims do not have rights to appeal and do not have rights to information. So those are just some of the areas that we think are particularly strong. We do have several concerns, and they're in my testimony that I've sent to you. But in order for a person, this first that I'm going to raise is about the definition of vulnerable adult, which is on pages 12 and 13. In order for a person to be determined clinically eligible for long-term care Medicaid waiver services, they must be evaluated by a professional within the Department of Vermont Health Access, or DVHA, and be found to meet the clinical criteria for nursing home level of care. A large part of the intent of this bill is to update the APS statute to recognize the changing landscape of care for vulnerable adults. Many more people choose to live at home or within the community than in institutional settings, and the state makes those investments each year. It is very much in alignment with this prioritization of home and community-based services to ensure protections within that system for the people that it serves. Currently, recipients of long-term care Medicaid waiver services still have to pass the APS functional test and are not infrequently found to be ineligible for protective services despite meeting the criteria for nursing home level of care. This is confusing, firstly, and an unnecessary waste of APS resources. The DVHA determination should be adequate, and as such, we advocate that clinical eligibility within long-term care Medicaid waiver services count as automatic eligibility for APS. So in the current definitions on the House side, it was moved out of automatic eligibility and moved into Part C of the definition, which is where that functional test happens. And so we are advocating that the clinical eligibility be moved up into Part B, which really speaks to home and community-based services. And I included that in my testimony. We also strongly oppose the department's request to add "the" to that functional test in Part C. In fact, we, Cove, cannot support the bill if the definition of vulnerable adult includes a requirement that the abuse and the disability be linked. We have looked through the statutes of other states and have not located any other state that requires such a linkage in their statute. To add this would be to change current law, which does not require this linkage. The bill as it stands also does not require that linkage and was supported by the House of Representatives and by the stakeholders. To parse out the times when a person is or is not vulnerable fails to consider the person as a whole and the totality of the circumstances that surround their living. It is our belief that to include a linkage boils down to victim blaming, putting the victim on trial to prove that they could not have protected themselves in the alleged incident. Essentially, the bulk of the investigation would need to be conducted up front before the case could even be opened, simply to determine if the abuse is linked in any way to the disability. This.
Can I ask her a question? I'm sorry, I just want to clarify on this point. So could you specifically say where in the bill you're talking about? Is it, you
The
said
department
paragraph
has made a
C
proposal
on page 13?
on page 13,
Is it,
part C. The department is proposing that the word "the" be added
okay, yep.
to protect the adult from the abuse, neglect, or exploitation, which was testified to last week.
Specificity is.
Where is it? Where do
So
they, are they?
C, 2 little I, they're suggesting impairment of the adult's ability to protect the adult from the abuse, neglect, or exploitation. And we are opposed to that change.
Okay, I don't quite understand
Well,
where
we'll circle
they're
back to it when
suggesting
we've
it.
got Edge Council with us.
Good. But it's a little word that has a big impact in your ability.
Sometimes,
to-
yes. No more those.
Okay.
Yeah. We have proposed alternate language that potentially addresses some of the department's concerns as well as our own.
Okay.
Ruby, I'm gonna interrupt you
Yeah.
because I'm going to leave and Senator Weeks is going to take over on my behalf and the vice chair. And then I will be back very shortly. I am looking at your.
Great.
written
Thank you.
testimony. Thank you. You bet.
So you can see our proposed language there, both to move the long-term care Medicaid waiver services into part B and the change in the language in part C.
Yes, okay.
A couple of other areas that we feel need attention. One is rulemaking. There are a lot of reforms in this bill and those are great. But we need some rules around the changes that have been made. The boundary line between when an assessment is appropriate and when an investigation should be required needs to be clearly articulated. In current law, there is actually no allowance for screening out of a case. It's not defined anywhere in current law, and it's mentioned in this bill, but we feel that this needs to be defined a little more clearly. Screening out a case would mean that the case is dismissed based on an intake screening rather than going through an investigation process. So we have proposed some additions to the rulemaking section as well, adding that standards and best practices for conducting both assessments and investigations should be included, and that the screening of reports needs to be clearly defined. And then the last piece in section 4 of the bill is under financial protections. There's, I think Katie called it work group light the other day. There's a little working group there about financial protections, and there's they are tasked with bringing proposed legislation back to you next fall, I believe. And we feel that stakeholders and older adults and vulnerable adults should be represented on that working group. Currently, it's Dale and Department of Financial Regulation and the financial institutions. But there are several of us who work in financial protections for vulnerable adults, and we would ask that you include COVE, Vermont Legal Aid, Disability Rights Vermont, and the Financial Abuse Specialist Team, which actually, interestingly for you all, Financial Abuse Specialist Team works in both Vermont and New Hampshire, and in New Hampshire, financial institutions are mandated reporters, which is actually the origin of this section, is whether they should be mandated reporters. So I think that having the perspective of both states there is helpful. Questions for me?
Katie, questions? Thank you, Ruby.
Thank you so
Appreciate it.
much for your time.
And Michael, Ebenezer, Benvenuto.
Good morning.
Good morning.
Thank you. I'm Michael Benvenuto. I'm the director of the Elder Law Project at Vermont Legal Aid. Vermont Legal Aid, we have advocating for vulnerable adults as part of our core mission. So our staff in the Elder Law Project, we represent people over the age of 60. We have a disability rights project. We have an ombudsman project that advocates for people in licensed facilities. So this is an issue we take seriously, and it's part of our core mission. We have a long history of looking at it. I was one of the attorneys that brought the lawsuit against Adult Protective Services in 2011. So I've been working on this issue continuously since then. As Ruby mentioned, I'm part of the APS Advisory Committee. We spent years talking about the statute leading up to this reform. And they've been, particularly looking at this bill, there's a lot of compromises, a lot of concessions that we made, but a lot of the reforms we're talking about, this is a really significant bill that's making a lot of significant reforms. This was something that they met openly with the advocacy community, and we worked through, as Ruby said, line by line, all the languages. So I support this reform bill and the concept. I think it's important. I think it's timely. But I want to talk about one issue, which is what Ruby Baker just testified about, because I'm opposed to the change to the definition of vulnerable adult, and I want to talk about why that's important. We're reacting to the memo from Stuart Scher, who's going to testify after us, where they're proposing a change to the definition. So the current law does not include this idea of a linkage or nexus between the allegation and the vulnerability. H-171 does not include this language. So this was considered in the House and they rejected it. But this is Dale's interpretation of the law. And so in the memo from Dale, they're proposing we often talk about this as the statute doesn't have a the, but they actually add the word the reported. So they're even trying to make it clear in the Senate proposal here that to make it clear that there is a linkage between in evaluating the person's vulnerability, and it relates to the ability to self-protect or protect yourself. And so whether your ability to self-protect is linked to the particular allegation. And again, as Ruby hinted, we have not seen that in other states. Other states are all over the map on how they deal with vulnerable adults generally and provide protective services. And in my survey of this over the years, we haven't really picked one state as a model. So it's not like any state really is doing best practices. And so part of our goal here is that Vermont, we're adopting many best practices and could be a model for many other states across lots of fronts. But not on this point. So as Ruby said, we've not seen a single state explicitly create a linkage between the person's vulnerability and the allegation of abuse. This does put the victim on trial, and I just want to explain what that means. But I should also back up before I get to that, which is this definition applies to APS's operation, what they investigate and what they substantiated, but it also applies to the relief from abuse statute. So where in a civil, which is what legal aid does for the most part, where we go to court and try to get a restraining order to protect the vulnerable adult from abuse. So the same definition, the same standards apply. The statute regarding relief from abuse, the relief you can get is actually one of the changes here in the bill that we support and we have suggested. The reason this change puts the victim on trial is because it asks the question, why didn't they step away? Couldn't they have said no? Could they have left? Why did they give their money away? And those are the cases we see. That is what that question raises. And Dale, in their memo, they talk about a Supreme Court case, which was a legal aid case. And I think it's a really good example of how dangerous adding this is to the statute and why you're asking you not to do it. That case involved a young woman with a developmental disability who was like 17 to 20 when this was going on. And she was sexually assaulted by her best friend's father. And so the argument that her disability and the abuse to her needed to be linked, or the court had to find a link, a nexus, that was made by the defense attorney. That was the argument the defense attorney made, but that was not proven. particularly that she could have resisted his sexual advances, or that she was making independent choices when she chose to go to his house in which the assaults had occurred. And so to be considered vulnerable under Dale's suggestion, she'd have to prove that her disability impaired her ability to resist his sexual advances, which just seems like completely the wrong way to think about the question. And so when I think about it's a philosophical question. We think of vulnerability as being evaluated independently of what is occurring to the individual at any given moment. Somebody may be vulnerable and they're not getting abused that week or that month or that year. That should be the majority of the situation. So we need to have a standard by which we evaluate vulnerability independently of what particular conduct may or may not be occurring. For APS, we think this needlessly complicates the question for them, because in order then to determine whether or not there's a nexus between the vulnerability and the abuse, they then have to do a full investigation and figure out all the nuances and details of the abuse, what occurred, why it occurred, the circumstances of why it occurred. And instead of just determining this person is clearly a vulnerable adult, which is, I back up in our context, we do file reviews. It was a product of the lawsuit. But then Dale has been willing, and APS has been willing to do them voluntarily now for many years. So quarterly we meet and they produce files to us that are redacted. And as part of the APS committee, we review them and talk about these policies and practices. And we've seen cases where APS then spends months, years wrestling with the question, is the person vulnerable adult? When, at least from our perspective, from like outsiders looking in, it's often obvious that the person is a vulnerable adult. Now, the circumstances, the nature of abuse, whether they can substantiate or not, there's always a lot of complicated questions, but the core question of vulnerability is often fairly straightforward for our impression. This is just one aspect of the definition. There are several other overlays to it. And we've seen cases where APS has investigated for literally years, and then they unsubstantiate the case after years of investigation, finding that the person was not a vulnerable adult. They talk about budget neutrality and the argument that this somehow expands their mission. I guess we just disagree with that first. This is already current Vermont law, so it really shouldn't impact budget neutrality after following current law, because they're proposing a change to Vermont law. But also practically, they'll get an allegation that somebody is a vulnerable adult and they're being abused, neglected, or abused. Under their current policy, they do what's called a field screen if they have a question about vulnerability. And what that means is that they would go and meet with the vulnerable adult to do that in-person evaluation to decide, to really evaluate before they conclude out of hand that the person isn't vulnerable. And so part of the concept of creating the assessment track, which is one of the major reforms of this bill, there's two different tracks for APS to operate in. If there's really a substantial question about whether somebody's vulnerable, then that would be an example of a case where they may do the assessment track anyway, where they would do the assessment track. And so they have to making that determination about the linkage or the nexus involves, doing an investigation, meeting the victim, doing all that work. So from our perspective, it doesn't seem like there's no difference in the level of resources. It actually increases the resources each case that APS has to devote if they have to uncover evidence of the nexus. So Ruby had mentioned this, but I also submitted written testimony. I should have said that up to that. Ruby and I did coordinate our test. We did talk about what we were testifying about. I support the things that she testified to. The written language in my testimony and the proposal by Ruby, I think they're the same. At least we tried to make them the same language. So we are aware of sort of some of the concerns about Dale, that the definition of vulnerable adult, like that anyone with any kind of disability could be considered a vulnerable adult. We don't think that's a reasonable interpretation. And again, many states operate in Vermont. Currently, that's not the current law. But we've been thinking about, well, how can we make this concept, this standard, clearer? And so that's our proposed language, which really then shifts the focus a little bit about we changed the word from to your ability to self-protect, that the concept would be because of your disability, you have an impaired ability to self-protect yourself, to provide for your self-protection. And so that's, again, a higher standard. And then as a result of that, you are at risk for abuse, neglect, or exploitation. So that becomes really a future inquiry, or it's not related to what's going on at any given time. It's thinking about your disability, your impaired ability to self-protect, and the scope of the risk that that presents to you. So that was sort of the framework that we came up with. Ruby talked about the choices, the language related to long-term care Medicaid, which is also in the definition of a vulnerable adult. Long-term care Medicaid is a super complicated, area of law. It's one of our things that we spend most of our time on. But it's sort of a housekeeping matter, which is, I think there's agreement that a determination that you're clinically eligible for choices for care for long-term care Medicaid, there's actually a slight difference. So it's long-term care Medicaid. But that's really a determination by Dale that individual already needs extensive services with personal care and their day-to-day living. And so that's essential. That should be basically conclusive that the person is a vulnerable adult. So I think there's an agreement that that long-term care Medicaid clinical eligibility would be that determination. So it's kind of a housekeeping matter, which is the House, in the blizzard of all the stuff they were doing, move that language down into kind of the functional test in like the beginning language. And for our reading, it's confusing there and kind of misleading. And so we were suggesting moving up into subsection B, where it fits with the home health services. So that standard is if you're getting home health services for 30 days, you're considered a vulnerable adult. This fits into this, or you can determine clinically eligible for long-term care Medicaid. You would also be in that same category of people like who may be getting home health services. The reason we're focused on clinical eligibility is because the financial eligibility process for long-term care Medicaid can take months, potentially. So we wanted to just make sure we're not dealing with people in that gap where they've been found eligible by Dale, but it may take another 6 months before they actually get fully approved by DEVA for the financial eligibility piece, and whether they may not be getting services. Some people may be found eligible and can't get caregivers who don't have services yet, and they would be determined eligible.
Michael, in the interest of time, I'm going to give you a 2-minute heads up. 2-minute warning.
I'll take questions. That was all I had.
Okay,
today,
very good.
so, yes.
Sorry to interrupt.
No, it's okay.
So,
Yeah, thank you for this, Mike. Couple questions. One is about this definition of vulnerable adult and abuse. And I'm wondering if a power dynamic is ever at play when you have a caregiver and someone who's being cared for. Because it does seem as though a power dynamic is often brought into play when you've got questions of abuse, whether it's sexual or other.
No, I think that's definitely true. And that's a really critical reason why we have statutes like this. Because when somebody is getting personal care, then they are dependent on that individual and for their day-to-day living, like taking a shower, going to the bathroom, or eating, or getting out of the bed. And then that does make them exposed to being taken advantage of, being abused, being the statute covers emotional abuse, but the clearest, I think that context applies across all the situations, but the one we see is the financial abuse aspect, where they give the person their ATM card and say, like, go to the store, because they can't go to the store themselves, and the person's going to the store. And APS sees this allegation all the time. This is part of their core investigations too. Then that person, over that pattern of time, over months, over years, but all of a sudden, why did they go to that store? Why did they buy that? And you develop this pattern where then the person is supporting them, and they're really taking advantage of that caregiving relationship. So that definitely comes to play.
Thank you.
Yes.
I had one other. Sorry. Legal Aid's been great about providing us with data because we're here to fix a problem, and knowing the gravity and the frequency of what we're dealing with is super helpful. Do you have any idea of how many calls you get, how many folks reach out to you in a given year with this issue?
Well, that's a great question. I focus on people over the age of 60. And so we do get Victims of Crime Act funding through Crime Victim Services to assist elder abuse cases. And so our target for that was 50 a year. And so I actually don't remember the numbers for last year, but we're over that number. So somewhere in the 50 to 80 cases where we actually identify the person as a victim of crime, and we do them. We often do the other related issues. So we might help somebody with Social Security. If they like were a victim of identity theft and they need to change their bank accounts, we advise them on sort of protecting themselves from identity theft. We do get involved in cases where APS is actually investigating, but that's a smaller number.
Okay, thank you.
Senator,
Well, first a question for you, because I was late. Sorry about that. Did Stuart already testify?
No.
Okay, no.
Stuart's gonna wrap. He's gonna
Okay,
wrap.
I see.
I'm gonna talk very fast.
Yeah, well, so, I mean, it's confusing. I wish that we had gone in the order so that he could have presented his proposal and then we could have heard the
Yeah.
refutation of it, because it was very confusing to me, to hear you guys suggest that you were not supportive of it, but then I was like, but what is the, you know? So, but now I think I understand it, and I'm interested to hear what Stuart has to say now that he's heard all of what you have to say. So I do have a question about, for both of you, I suppose. You heard Betsy's testimony, and wondered if you had concerns. We've been focusing on but what about her concerns about the negligently, and as it relates to healthcare workers?
Yeah, I think it's an issue, at least from, I've tried to, I apologize that you're getting asked to guess that question. I'm gonna say I've been trying to avoid taking a position on it.
Okay.
Because I understand, sort of the concerns on both sides. And I will say that was not one of the proposals that we really spent any time as part of the APS Advisory Committee wrestling with. So I haven't really seen Dale's justification for why they really think that's critically needed.
Well, I don't know if Dale's justification or not, but I've heard from a number of healthcare providers, and Betsy's testimony was consistent with what I've heard from healthcare providers. So I'm just wondering if we were to make that change, does that have the same impact as has? Okay.
Not from our perspective.
Okay.
It does potentially expand what APS does or does not do. It relates to the sort of scope of what falls under their jurisdiction.
Yeah, and then if I may, do we have time, or I can wait, I can hold this, but,
Please.
okay. Your example of the girl who was raped and the linkage, and it was a Supreme Court case, is that what you said?
The restraining order went up to the Supreme Court.
Okay, whether or not there was a linkage to her disability. I mean, I'm not sure I can formulate this question. This is like running around in my mind about like if she were raped, regardless of her disability, that is still rape. If it was determined, but then if someone is in a protected class, then it may be sort of, I'm not a lawyer, so the adding on top of, it's like, even, for lack of a better word, and I know this is wrong, hopefully it doesn't offend anybody, but it's like even worse rape, if you know what I mean, that because of her disability. And so I'm trying to get at and having not heard Stuart's testimony, trying to get at is that what they're trying to say or do you not want any linkage to say that it could be even worse if somebody's a vulnerable adult? Or does what I'm trying to ask make any sense?
Well, it does.
I'm trying to wrap my head around all of this, and so.
Well, I think you're asking actually two different things. I'll just cover them. Which is one, yes, this law does protect like a special population, right? And so that's part of the specific intent. Most of this behavior is potentially the crime.
Right.
And
that's what I'm saying. It's a crime regardless.
It may not be anything the police or like a state's attorney would actually prosecute, depending on what happened. But a lot of the behavior that's covered by the statute could very well be considered criminal. But the law is intended to protect a special population that are vulnerable adults, like we have laws that protect children. So
right.
This is sort of a parallel framework for that. And yes, it does, sexual Abuse is one of the behaviors covered by the statute. And there are criminal laws that overlay this too. So abuse of a vulnerable adult is also a criminal statute and a criminal violation. So I should have written down the second part of what you asked me. But
No, that's okay.
fine.
I mean, I didn't formulate it well. I'm just
Yeah.
trying to sort of make it straight in my brain. So it's okay. It's fine. I'll think about it and maybe get back to you with a better question.
Yeah.
Okay, thanks.
So, good. Thank you, Michael.
Thank you.
And, Stuart Sure.
Now that everybody says they hate what you're gonna say, Stuart, don't.
I'm used to that.
Oh, okay.
So thank you very much. Do I have 5 minutes? Is that where we're ending at
You
10?
have 5 minutes
4
plus,
minutes. 5 minutes.
given the gravity of your testimony. So,
Okay, I want to keep that in mind, but thank you very much. And for the record, Stuart Scher, General Counsel for the Department of Disabilities, Aging and Independent Living, also known as Dale. So you have heard from Dale and Adult Protective Services on several occasions, I think in both writing and through live testimony of our APS Director, John Gordon, and our Director of Licensing Protection, Joe Nussbaum, who's on the screen today. And that testimony addressed specifically the mission critical issues of Dale. And so I was prepared before I walked in here today to leave a lot of that to the memo itself and address two discrete issues that were not addressed in the memo. But in light of what I've heard today, I feel like I need to expand my comments a little bit. So I guess I'd like to start with the definition of vulnerable adult that Michael and Ruby just addressed in section 6902, 34C, 2i. And again, forgive me, this is in our written testimony, but I would like to go over it again and answer any questions you might have, because it is a very important issue. But before I jump into that, I do have some very critical testimony to provide about what we heard with respect to the mens rea or the negligence standard for abuse and neglect. And I would like to make sure we get that on the record today, because I think that may in fact resolve some of the concerns that we heard today, if the committee is interested in taking that proposal. But because of the recency of the statements about the vulnerable adult definition, let me start with that. So the current definition in C2i talks about some impairment of the adult's ability to protect the adult from abuse, neglect, or exploitation. And the department is proposing that phrase be reworded to say some impairment of the adult's ability to protect the adult from the reported act of abuse, neglect, or exploitation. And what that does is it sets up that nexus requirement that we believe is critical for a number of reasons. And that's laid out at the end of the memo that I'm just going to cover now. So the definition of vulnerable adult has been at the very core of APS's mission and establishes the very purpose for this bill. The definition has been discussed for ad nauseum, some would say, and in the drafting of this bill, and has received extensive attention from both the department and the advocacy groups that you've heard from today. Despite the attention, the current definition doesn't make it clear who is, or perhaps more importantly, is not a vulnerable adult. The lack of clarity in existing statute and the proposed bill has caused endless confusion and has failed to provide the department with a clear scope of APS's own operations. The debate has been whether there needs to be a legal nexus between the nature of reported abuse and the abuse of the individual's vulnerability. Some advocacy groups have suggested that other states have no such nexus, and therefore Vermont shouldn't have one either. While that argument is technically true, it ignores that no other state has as broad a definition that renders any adult with any general impairment to protect oneself from any potential maltreatment, whether alleged or not, a vulnerable adult. Other states have narrowly drawn their definition of a class of individuals that could be considered vulnerable adults. Although every state does it differently, common approaches include restricting the category of vulnerable adult to individuals who are institutionalized or reside in residential homes, individuals who receive or are in the process of applying for disability-related benefits, individuals with prior diagnoses, or individuals who require specific levels of assistance to complete daily tasks. Vermont lists every one of those categories already, but following those standard definitions in subsection C, 2i, which broadens vulnerable adult to every Vermonter with some impairment of the adult's ability to protect the adult from abuse, neglect, or exploitation. The debate hinges on whether the connection or the should be added, which changes the language to some impairment of the ability to impairment of the ability from the reported act of abuse, neglect, or exploitation. The proposed definition that's in the bill is so sweeping and unrestricted that in theory, it could include nearly every adult in Vermont. And you heard from Joe Nussbaum last week, giving the examples of someone who is height challenged or has who wears glasses. Potentially, those individuals could be pulled into the definition of a vulnerable adult. And in its memo, the department also cited to the case that Michael mentioned in Smith v. Wright. And while the department doesn't disagree with the facts in that case, the issue there was, well, what the Supreme Court clearly held in that decision was a recognition of a linkage between the individual's ability to protect oneself and the alleged maltreatment. And in fact, the court specifically said, quote, the relevant part of the definition of vulnerable adult states that a person over 18 years of age is a vulnerable adult if they suffer from a physical, mental, or developmental disability that impairs their ability to protect themselves from the abuse, exploitation, or neglect. In fact, the Supreme Court held the lower court had specifically concluded that plaintiff's disability impaired her ability to protect herself, not against any and all generalized abuse, exploitation, or neglect, but rather against the defendant's sexual advances. So the court, even though it didn't address the issue because it hadn't been preserved on appeal, the court in its opinion talked about the fact that the lower court had found the defendant was a vulnerable adult by virtue of the nexus between her specific disability and her inability to protect herself from that particular offense, not for any and all offenses that could have arisen.
So Stuart, so in short, you're supporting the inclusion of the.
Yes.
Okay.
Any
I'm
way you want to say it. Yes, and so adding the word the serves to respect the dignity of persons with disabilities by acknowledging that not every disability or infirmity renders one vulnerable to every type of alleged maltreatment. For example, an individual with a physical disability or infirmity of aging without more may be unable to protect themselves from abuse or neglect, but there may be no evidence of an inability to protect themselves from financial exploitation. And I often use the Stephen Hawking example. One would say that Stephen Hawking may have been vulnerable if the allegation were abuse or neglect due to his confinement to a wheelchair. However, for those of you who knew of Stephen Hawking, one would probably not suggest that Stephen Hawking would have been a victim of financial exploitation necessarily. So to render someone like Stephen Hawking a victim for all purposes and not requiring a nexus between the allegation and the impairment, it does a great disservice to individuals who are vulnerable or have disabilities. And so equally important is that the inclusion of the word the places the burden of proof on the department where it currently exists and belongs. The department should be required to demonstrate a nexus between the ability to protect oneself and the alleged maltreatment before substantiating an alleged perpetrator for the abuse, neglect, or exploitation of a vulnerable adult and placing that individual's name on the adult abuse registry. And when relying on this definition and such a linkage can't be shown, substantiation should not follow. So those are my comments in response to the definition of vulnerable adult. I want to also jump to the other very critical issue, which was raised at the beginning of testimony today around the mens rea element. And let me just pull up so many different screens here. So Dale does appreciate the concerns that were raised by the Vermont Medical Society, by the Nurses Association, and others with respect to the potential impact that including medical professionals in the definition of abuse and neglect and expanding that to include negligence would have on their practices. We do, however, feel very strongly that there needs to be, the law needs to specifically address the situations in which an individual commits negligence and harms a vulnerable adult. To simply say that there is another body or licensing board that will address that doesn't necessarily address the situation in which the licensing board may strip that individual of their professional license, but that individual could still go out and perform services for vulnerable adults without the need to be licensed, and there'd be no way to track that individual. The only way to do that would be to ensure their placement on the adult abuse registry. That being said, in light of those concerns, the department does propose a temporary carve-out to the negligence mens rea for medical professionals for the reasons that you've heard today. And what we would say is abuse means any treatment other than medical treatment provided by a licensed medical professional that purposely, knowingly, recklessly, or negligently places the life, health, or welfare of a vulnerable adult in jeopardy or is likely to result in impairment of health to the vulnerable adult. We think that the definition that negligently should be added to the statute. However, we understand the concerns of the professionally licensed individuals and the impact it could have. So we would propose a temporary carve out for those individuals, but also we would ask that in the interim, much like the language in Section 4 of the bill, that they'll be directed to perform a study or submit a report in collaboration with the stakeholders to include the Medical Society, the Office of Professional Regulation, the Medical Practice Board, and others, as well as the stakeholders that we've heard from today, that would address the issue of how professionals, medical professionals, their obligations are addressed in other states, and we can do a more comprehensive search of those other states, and also think about ways that we can balance the interests of Dale in protecting vulnerable adults with the interests of the medical professionals and trying to limit the impact on them. So that's the proposal for the definition of abuse. And with respect to neglect, very similarly, creating that carve out for professional caregivers. Neglect means purposeful, knowing, reckless, or except for the negligent failure or omission by a licensed medical professional, negligent failure or omission by a caregiver that has resulted in or could be expected to result in physical or psychological harm, including a failure or omission to ...
Is that in your written testimony or is that an addendum?
That is not in that
Okay.
formal written
I
testimony.
didn't see it in here.
No, I provided that to Katie, and I can certainly.
We have some language suggestions.
Okay,
Could you send that
absolutely.
so we could see that language as a
Absolutely.
committee, not just Katie?
So
Absolutely.
so what I'm looking at here, it does that doesn't include the carve out you just talked
It
about?
does not.
If you're talking about the April 18th,
Yeah, well,
oh, no.
whatever you sent us,
April
yeah,
12th.
April 12th.
okay,
Yeah,
Yeah,
it
it does
dates it on that.
okay, so, all right, thank you.
May I, if you have 3 more minutes, there is one other piece that I think is very important with respect to the Dale's access to records and the language that's in the.
Okay, and if you can get it to us in writing, that would be helpful.
I can certainly
It would
do
be
that.
1 minute,
Okay, perfect. So
and I'm literal about that.
I will, well, stop me mid-sentence, please.
Uh,
So the current language in 6911A does appear to require individuals in possession, so custodians of records or covered entities to disclose records to APS without unnecessary delay.
mhm.
The House Judiciary Committee put a clause at the beginning of that section that says subject to confidentiality or privilege protections, which creates an ambiguity. Like, is that a mandate or is it still subject to those confidentiality protections? It's important because if there is a mandate to turn over documents to Dale upon request without unnecessary delay, if they're needed to perform its investigations. It's an exception to the HIPAA requirement of getting an authorization from an individual. So we want to be very clear to the public and to covered entities and the records custodians that you can't assert a confidentiality protection under HIPAA because there's a mandate, and HIPAA allows as an exception to the authorization requirement if something is required by law. So we want the statute to be very clear that it's a requirement under law so that there's no delay in getting those documents.
Thank you.
Okay, I'll
All right,
submit that in
good.
writing, but thank you.
No, and what we need to get it in writing so that we can look at it. The committee will be having discussions, obviously, about the bill and trying to resolve some of the conflict that we're hearing about.
I have one last question.
Yeah.
What the carve out and the study, what time period are you looking at?
We would look for the studies for the report to be provided by fall. November 1st, I think, is the section 4 requirement.
Okay, thank you.
Thank you.
All right, committee, we're good. We're gonna move ahead. We've had some, Mary Hayden, I don't know if Mary, you're here. Thank you for being here. We have your testimony in writing. I know you submitted it to me last night and yesterday, and we appreciate your availability. We may circle back with that. Thank you. Okay. So we're going to move on to Jen Carby, who is here. And before we do anything else, Jen, I think that we should look at H89 proposal amendment.
I think you have witnesses who are going to be here.
Oh.
Yeah, we got a couple people joining us around 11 for that.
Oh, we do. Okay, that's good. I didn't know. Thank you for bringing it.
Or what? Which bill?
481.
Yeah, so I'm really just here to take up Katie. She gets there for 481.
What is it? I didn't hear it.
Oh, I'm just here to take notes for Katie on 481.
Okay.
She has to be upstairs, and then I with you on 473.
473, right?
And then 89.
Okay. I have to leave here at 11:30, so I want to do 89 before that.
89, is that on our agenda?
No, I'm bringing a proposal
Which
of
bill
amendment
is
to the committee for consideration on MIFA.
Yes, right, okay.
Thank you.
And OPR and DMS
Excellent. Okay, good, perfect. H81, so we have Caitlin Quinn, who is here. There you are. Thank you for being here. We're now turning to an act relating to public health initiatives to address death by suicide. And Caitlin, thank you for being here to testify with us.
Thank you so much for having us here today.
Okay, why don't you go right ahead, introduce yourself for the record, and we will listen to your testimony. Do we have anything in writing from you? I don't see it.
So I do have some slides prepared, but it doesn't look like I have the ability to share my screen.
Okay, we can do that.
I got you. You're good to go. And I think she's still sharing the same slides that are listed in the notes.
Oh, under Nick Nichols' name, we have some slides. So that would be, you two are working together. Good.
Correct. Yeah, we're both with the Department of Health. So we have a joint slide set, and Caitlin's going to go first.
Okay, thank you.
Well, good morning, everyone. I'm so happy to be here today. Thank you so much for inviting us. My name is Caitlin Quinn. I'm a public health analyst at the Vermont Department of Health, and I work full-time on suicide prevention epidemiology. I've been with the health department since 2018 and have been working on suicide prevention data for a little over 2 years now. I bring a lot of passion to my work, and I really hope that this data can help make a difference and impact the lives of Vermonters in preventing suicide. So today's data presentation will be short and sweet. I'll try to keep it some of the high-level data points. We will focus on both suicide morbidity and mortality. This slide I've included to help illustrate the burden and scope of the problem for Vermonters who struggle with suicidal thoughts or behaviors, self-harm, and who have attempted or passed away from suicide. Starting at the top of the pyramid, we have the average number of lives lost each year to suicide in Vermont, which is 122. As you move down the pyramid and look at some of our morbidity data, you see that the numbers get larger. In 2018, we know that approximately 1,900 Vermont adults attempted suicide within the past year. We also see, on average, 1,000 hospital visits a year for self-harm. Intentional self-harm is doing something to intentionally inflict pain or suffering, and there may or may not be intent to die. Most of the times for these types of visits, it's intentional poisonings or cutting. We also know from our syndromic surveillance data that there are on average, 4,800 emergency department visits a year for a suicide-related reason. And a suicide-related reason in this context would be a visit for suicidal ideation, so thinking about suicide with or without self-directed violence or self-harm. This graph shows the trend of suicide deaths in Vermont over the past 10 years, from 2012 through 2021. The blue dot shows the rate of death for Vermont residents. The orange dot shows the rate of death of suicide in the US. Rates here are expressed as per 100,000 residents. And the green bars show the number of deaths by suicide. Just a few key takeaways from this data. Vermont's rate of suicide death has increased over the past 10 years. Vermont's suicide rate is higher than the US and has been every year for the past decade. And in 2021, Vermont saw a record both in the number and rate of deaths due to suicide. This slide looks at syndromic surveillance data showing suicide-related emergency department visits. The earliest data that we have from this database is from 2017. This graph shows both the number and rate of visits. Rates here are expressed as per 10,000 ED visits, and rates are important because they help adjust for different population sizes over time. So the number of visits are in blue, and the rate of visits are orange. A few key takeaways from this data. The rate has increased since 2017, and in 2022, the rates were the highest over the 6-year period, where for every 10,000 emergency department visits, 239 of them were for a reason related to suicide. This slide shows who is being impacted the most by suicide and self-harm. The graphs show the rates of intentional self-harm and suicide death by age and gender. These rates are expressed as per 100,000 residents. For suicide deaths, we see that the highest rates are among those 25 years and older. We also see that males have a suicide death rate that is 4 times higher than that of females. For self-harm, the highest rates are seen among those who are 15 to 24 years of age. And females have a self-harm rate that is nearly twice that of males. Okay, so this last slide, I promised I'd keep it short and sweet. I just want to talk a little bit about means, or what people are doing to harm themselves. And means look very different for morbidity and mortality. Morbidity being self-harm, mortality being suicide deaths. Among suicide deaths, over half of people who have died used a firearm, 52% in 2021. 24% died through suffocation or hanging, 18% by poisoning, and the remaining categories all occurring at much lower frequencies. Our morbidity data shows that nearly half, or 48%, of visits are for poisonings. Poisonings include things like intentionally taking too much of substances like prescription medication, over-the-counter medication like Tylenol, household substances, and it also includes carbon monoxide poisonings. The second most common form of self-harm is cutting oneself intentionally with a sharp object. The remaining forms of self-harm occur at much lower frequencies, and they're included on the slide for reference. And now I'm going to turn it over to my colleague, Nick Nichols, who will talk a little bit more about what we are doing at the Vermont Department of Health to address suicide. Thank you so much.
Caitlin, we do have one question for you from Senator Williams.
Hi, Caitlin. Do any of these figures include physician-assisted suicide?
No, so in this data just looks at suicide deaths. And for deaths of dignity, they are categorized separately and not included.
Thank you.
So what you're talking about is patient choices at end of life, which is legal,
Right.
and which would be. Go ahead. Senator Hardy has a question.
Caitlin, could you put, well, I guess, well, first of all, I, what you said was short, but not sweet, so I would just be careful to not categorize it as that. But it was interesting and sad. And I wonder if, how you capture this sort of self-harm, is that also considered attempts at suicide, or where do you draw the line between attempts of suicide and self-harm? And also there are things, just the second part of that question, that people do that is self-harm that, you know, does it include things like excessive drinking or risky behavior, like driving your car too fast and, you know, doing things that may be self-harm but might be actually categorized as something else? Do you know what I mean?
Yeah, so I can tell you a little bit more about how hospital visits for intentional self-harm are determined. So we use hospital discharge billing codes to look at intentional self-harm. Intentional self-harm would include suicide attempts and then also intentionally harming oneself that may or may not have been, you know, the intent to take their life. So for the motor vehicle example that you mentioned, if someone intentionally crashed their vehicle because they wanted to hurt themselves, and then the hospital visit had that noted and their discharge diagnosis was intentional self-harm by motor vehicle, they would be reflected in this data.
Okay, but unless the individual admits to the fact that it was intentional, you wouldn't know necessarily. They could say, oh, that was an accident that I hit the tree, when in fact they may have been trying to self-harm.
Yep.
And okay, and it wouldn't necessarily include things like binge drinking or excessive drinking or other behaviors that are sort of have unfortunately dual purposes, that they are self-harm, but they're also.
Yeah, not always would be captured as intentional self-harm.
Okay, so point being is that the data could be even worse and more, we don't have the capability of categorizing and collecting it completely.
Yeah, there is a chance that our data is underestimated.
Yeah, okay, thank you.
Senator Gulick has a question.
Thank you. Yeah, so to follow up on Senator Hardy, so is excessive drinking, is that considered poisoning? Is that there's part of your data was poisoning? Was poisoning,
yeah. So if the person intentionally harmed themselves by ingesting too much alcohol and that was noted in their record, and they had a discharge diagnosis for intentional self-harm by alcohol, then they would be captured. But things like alcohol intoxication where no intent is noted, that would not be reflected in this data.
Good?
Yeah.
All right, thank you. So now back to you. Who is next? Is it Nick?
Yes, hi everyone. For the record, my name is Nick Nichols. I'm a suicide prevention program coordinator with the Department of Health, and so I'm a co-worker with Caitlin, and I currently oversee two federal grants that the Department of Health has focused on suicide prevention, and we work very closely with the Department of Mental Health, and so I think between myself and then your next presenter, Chris Allen, we're going to be just sharing a lay of the land in terms of, you know, now that it's clear that Vermont is, in terms of our numbers, we see some pretty alarming trends. we're going to be talking about what both departments are doing to hopefully address this issue in a way that starts to reduce these trends and reduce the number of deaths in Vermont. So I'll be talking about two different grants. Before I start, I did just want to share this one slide, and I think it's really helpful in terms of the how Vermont approaches suicide prevention. We sometimes we'll get asked, like, why is both the Department of Health and the Department of Mental Health focused on suicide prevention? And we feel like it's incredibly important because as an issue facing Vermont, we need to be taking a public health approach to suicide prevention. And, as you probably know, using a public health approach in general means that we're focused on protecting and improving the health of entire populations and their communities. And for the issue of suicide, it's incredibly important that we take a broad public health approach and include primary prevention and upstream activities as part of what we do, because we know that there are many people who are struggling with issues of suicide who are at risk, who are not asking for help or not seeking help. And so, in fact, when you look at the percentage of people who die and the number of people who die here in Vermont, only about a third of Vermonters who die by suicide are actually engaged in mental health treatment when they die. So to us, that means that in some cases, or in many cases, people are not asking for help. They're afraid to help, or because of stigma, they don't feel like they can seek out support or even talk to other people that they're struggling. Or in some cases, they may try to ask for assistance or treatment, but they're not getting what is helpful for them. And so because they're not engaging in treatment. And so when we take a public health approach to suicide prevention, it means that not only do we want to enhance and improve our mental health treatment system, we also need to expand our approach. And so we expand suicide prevention beyond our mental health treatment system into communities, healthcare, and the general public. And I've just included a quote here from a public health campaign that we started last fall called Facing Suicide VT. And the tagline of that campaign is that all Vermonters have a role in facing suicide. And so you'll see in some of these slides, some of the approaches are very focused on improving our mental health treatment system, but we also want to make all Vermonters aware of this as an issue and make all of us feel like we know what to do, both if we are struggling and need to find help, and if we know someone who's struggling, how do we help them? So at the Department of Health, I think it's also just, yeah, sorry.
Nick, Senator Gulick has a question.
Thank you.
Thanks.
Looking at the previous slide, yes, thanks. I was wondering if you could tell us a little bit more about what mental health treatment is. Is that psychotherapy, or could it be just prescription for medication once a year?
So, in terms of evidence-based clinical mental health treatment for suicidality, there's a broad set of treatment approaches. Some of them do include medications, but a lot of the clinical treatment that we're promoting is different types of psychotherapy that would be provided by a licensed mental health clinician. For instance, there's a certain type of cognitive behavioral therapy specifically for people who are struggling with suicidality. There's also another approach called collaborative assessment and management of suicidality. And so there are specific types of therapies and counseling that we know help people and reduce the rate of suicides. So that's a big component of what we're pushing out is clinical counseling and treatment.
Thank you very much for clarifying that.
Yeah, absolutely. Absolutely. So I also like to share this slide just, in terms of when you're implementing suicide prevention strategies, it's helpful to understand that there's actually a broad set of evidence-based approaches that you can take. Some of them are very much focused on when someone is in crisis or actively experiencing thoughts of suicide, how you identify and support those people in those moments. But there's also important strategies that are more focused on primary prevention or upstream, helping improve things like connectedness. The more connected you are to your social group and to other people, the lower your risk of suicide, as well as things like enhancing life skills and resilience. We know those things can also help reduce the risk of suicide. And then in addition, we also know that for people who have experienced a loss or suicide loss, that actually increases the risk of that person experiencing thoughts of suicide. And so we're also promoting something called postvention, which is basically a broad set of approaches to support people who have experienced a suicide loss and supporting them in the right way. And so when you're looking at suicide prevention strategies, it's actually a broad set of things that include things like mental health treatment, but also things that are more upstream, as well as following up with people if there was a suicide death. And then you also see in here, there's something called reducing access to lethal means. We also know, based on the evidence, that when people are experiencing thoughts of suicide or at risk of suicide, if you can reduce their access to things like firearms or medication, it greatly reduces the risk of that individual attempting to take their life. And in often cases, if you can temporarily reduce access to lethal means, it gives you more time for someone to intervene or to connect with that person and provide them support. And their impulse to act on those thoughts may pass, and you're able to get them into effective treatment. So I'm now just going to quickly talk about two different federal grants that the Department of Health has right now focused on suicide prevention. One is from the Centers for Disease Control and Prevention, and we call that our Comprehensive Suicide Prevention Grant. And then we also have we just got a grant from the Substance Abuse and Mental Health Services Administration through the Garrett Lee Smith Youth Suicide Prevention Grant. So there are our Comprehensive Suicide Prevention Grant, or the CSP grant, that's a 5-year grant from the CDC, and that started in September of 2020 and ends in August 2025. And so we're about halfway through that grant. And the focus of that is primarily on working with working age young adults and adults, and focusing on both decreasing deaths of suicide as well as morbidity associated. And so our primary populations are Vermonters ages 15 to 64. We also do have several focus populations. These are groups of Vermonters that we know are experiencing rates of either suicide deaths or issues related to suicide at a higher rate than a general population. And so some of our programming is specifically focused on some of these populations. And as I mentioned before, because we're taking a public health approach to suicide prevention, we're implementing activities quite broadly across various community programs, trying to work with employers as well as the healthcare systems, and reaching out to the general public. And as part of that, we want to improve public awareness and access to suicide prevention resources for all Vermonters. And as I think you'll sort of hear a common theme is, a lot of this work crosses both the Department of Health and the Department of Mental Health. And so this grant is actually co-managed by both departments. So I won't get into a lot of detail about the specifics of what we're doing, but I just want to touch on some of the various activities and give some examples. So as part of the grant, it's allowing us to enhance our data surveillance, which means improving how we collect and use data to hopefully reduce suicide deaths as well as morbidity. And so Caitlin actually is funded through this particular grant, and a lot of her work is focused on improving our data analysis and making that available to our departments and other folks to improve how we're doing suicide prevention. As you may have seen in H481, there's reference to something called the Suicide Data Linkage Project that's supported through this grant. That's a pretty massive undertaking that Caitlin was working on to pull data from a broad set of state programs as well as community programs and cross-reference that with people who have been dying by suicide to look at the various paths and programs that people may have gone to or encountered prior to their death. And we hope to use that data to better identify where are the places where we should be doing more intervention and doing a better job identifying people who may be at risk or experiencing thoughts of suicide. And so we're hoping that the information from that data, which will be completed this summer, will inform a lot of work around how we're trying to improve suicide. We're also working to expand something called suicide awareness trainings, which are meant for social service agencies as well as community partners. These are folks who are not clinicians, but we feel like they should be able to and could learn how to recognize and support people who may be struggling. And so we're making that available broadly around the state. If you yourself are connected with a community program that has an interest in suicide prevention, let us know. We have the training available free to anyone who asks for it. As I mentioned before, there's a strong focus on reducing access to lethal means. And so we have several strategies, both working with programs to implement something called counseling on access to lethal means, which is sort of how to talk with people who are at risk of suicide and come up with a plan for temporarily moving things like firearms and medications to a different location. And it also includes things like promoting safe storage among the general population, because we know that if firearms, for example, are unloaded, locked, and ammunition is kept separately, it reduces the risk both of unintentional self-injury as well as suicide. We're also working to expand a lot of different supports for different at-risk populations. One of the things that we found through our enhanced data analysis is that there are people who work in certain populations who are experiencing higher rates of suicide mortality or morbidity. And so we have several initiatives focused on first responders as well as farmers and the construction industry, improving supports for people who work in those areas because we know they're at higher risk.
Uh-oh.
Hi, I'm here. I heard noise, but I couldn't make out what was saying. Was that a question from the committee?
Froze. I was checking to see if you were frozen.
Okay.
But you're here. Okay, it was the hallway noise, yeah.
Okay, good. Phew. I'm in a state building, so hopefully the internet connection is decent. You would think it would be. So, but anyway, so we have some work to expand. As I mentioned before, postvention, which is sort of improving how we support people after a suicide loss has occurred. We also have a couple different initiatives engaging with healthcare providers, both emergency departments as well as primary care practices, to help them improve how they identify when one of their patients might be experiencing issues of suicide, and making sure they're set up really well to both do an immediate risk assessment and safety planning, and then also help ensure that that person gets connected to appropriate mental health clinical treatment. We also, for rural Vermonters, we know that accessing a therapist who's trained on evidence-based suicide treatment can be a challenge. And so we're also working to improve suicide mental health care by expanding access to telehealth. And then lastly, as I mentioned before, we have a public health campaign to raise awareness around suicide called Facing Suicide VT. And if you haven't checked it out, I encourage you to check out the website. It's really designed for any Vermonter can go to that site and learn more about both if they're struggling, where they can get support, as well as if they know someone that they're worried about, how to support that person. And then also related to that, we really are hoping to destigmatize people's attitudes about talking about suicide. And so we actually have a page that includes real stories of different Vermonters who talk about how they themselves have struggled with thoughts of suicide, or how they've worked to manage their own experience of losing someone to suicide. So I won't go through this slide, but Jeff, if you're interested in knowing more about some of the outcomes that we've been able to achieve under this grant from the last year, I've included that for your information. And then I'm going to really briefly touch on our Garrett Lee Smith Youth Suicide Prevention Grant, which is a new grant that we received in the fall of 2022. That grant will run to August 2027. It's focused on reducing suicide deaths and attempts of Vermont youth ages 10 to 24. With that grant, we also have different focus populations of groups that we know are experiencing issues of suicide at a higher rate. And so some of our programming is focused on some of these populations. This grant is focused both on improving our youth treatment centers, as well as providing more supports for schools, as well as what people call the third spaces. These are, youth programs like after-school programs where youth may be showing up and may be struggling. We want to help them also improve how they can identify and support people. And then we also want to do work to connect with youth who may be connected with the child welfare or juvenile justice system. And then we're planning to do some activities just in general to promote youth mental health and wellness, to just encourage youth to practice more to be involved in more things that will help improve their mental health and wellness. And then it also includes supports for families, both for families who have a youth that's struggling with suicide, thoughts of suicide, as well as for families who have lost a youth to suicide. And then, as with our other grant, this is led by the Department of Health, but we coordinate it closely with the Department of Mental Health. And then I know we're probably short on time, so I won't go through this slide, but this slide here has an example of a lot of the different practices and strategies that we'll be implementing through the Garrett Lee Smith grant. So I will stop there and just find out if anyone has any questions.
Wow, that's a lot. Thank you.
Yeah.
That's a lot of work. And so integral to what you can take your slide down. Why don't we take the slide down and we can see that it's integral to what we're looking at in the bill itself. So we'll circle back to this, and then having those references is also helpful. I know last year this committee worked collaboratively with the Education Committee on designing some ESSER II fund grants that would help kids' mental health. And I'm thinking that we're going to have to get a report back on how that's going. And I know that the mental health first aid folks were very much involved in that as well. Before I go to questions, just want to see who else is here to testify as a continuation of what you're doing. Chris Allen and Terry LaValle are both here, is that right? And you're both going to testify. That's good. All right. And then Jennifer as well. No, okay, just checking. All right, good. So Senator Hardy has a question.
Thank you, Madam Chair. Nick and Caitlin, sorry, I was looking at the screen trying to remember who had testified. I just looked at the bill, and basically it seems like the bill just asks you to do what you're already doing and then make a report to us kind of like you just did. So I'm wondering, one, if you support the bill, and two, if you see a broader point to the bill. Maybe that's an unfair question, but it just seems like it's just doing what you're already doing, and maybe it's just here to make us feel like we're doing something. I'm not sure. What's the department's position on the bill?
Yeah, so I think in general, it's really, as I mentioned before, we want all Vermonters to take a role in facing suicide. So in general, it's really wonderful that the legislature is taking this much time to focus on suicide as an issue, and then trying to encourage the state and the Department of Health and Department of Mental Health to regularly communicate with all of you and to be in sync with what we're trying to promote. And so, I can't take a full position on the bill itself, but I can say we are always happy to come and report and share what we're doing, and then also get input from the legislature and your constituents about what we should be doing, more with, and then also having discussions around how we can coordinate all this. And so, yes, I think the bill would not be a heavy lift for our department, but we are really, like I said, we're happy to come and present. And as I mentioned before, one of the components of the bill mentions the data linkage project, and that should provide a lot of new data and information about where we're missing people and how we should be doing a better job catching people who are struggling. And so I think we'll be very excited about sharing that information and having discussions about how it can improve what Vermont is doing. So.
I will say that one of the important pieces is significance of having something like this and building a continuous connection between you and legislature, Department of Health legislature, is truly the acknowledgement that suicide is a public health issue. And so frequently all we hear about are regulations for firearms, and that suicide is connected with the judicial system. So I'm actually happy that we have this bill. It doesn't mean it's gonna leave here in the same condition in which it arrived. But, so I do appreciate your input, and we will take a little time later on to have a discussion about the bill itself. So, thank you. Senator Bullock.
It seems as though a lot, or some of your work anyway, is being funded by a grant or grants that will end in 2027. And I'm wondering if you're looking beyond that date and creating a plan for the post-grant world.
Yeah, that's a great question, and absolutely, yeah. You know, a lot of this work is funded through 5-year grants, one of which ends in August 2025, and then the other one ends in August 2027. And so I think that I don't want to steal Chris's presentation, but I think, you know, part of the hope for developing a statewide strategic plan is including looking at, you know, how is the landscape going to change? What are the resource needs that may increase after some of these grants go away? So I think, yeah, it's an important thing for us to be determining and figuring out. And I think part of the goal of the strategic plan is to identify where are those gaps, and have a plan for what we need to do when that funding goes away.
Okay, I'm going to suggest we move to Chris and hear your testimony. We've only got about 15 or 20 minutes left on the topic, so we should probably move ahead. Go ahead, Chris. Thanks for being here.
Yeah, good morning, everybody. I'm just gonna try and share my screen here. Just give me one moment.
You should be all set.
Okay.
But the other thing that, as we're just talking about the value of the bill, maybe there's something more we can do with it. But the notion of prevention is something that we have worked so hard on in this committee. And then taking that message outside of the committee so that we're not talking about violence and damage, we're talking about preventing some of those things that might cause violence and damage. Go ahead, Chris.
Yeah, so for the record, my name is Chris Allen, and I'm the Director of Suicide Prevention at the Department of Mental Health. And I've been in this role, in this newly developed role, since January of this year. So I just wanted to talk to you a little bit about some projects that I've been working on, or that are kind of under my purview. So the 988 Suicide and Crisis Lifeline. It offers 24/7 access to trained crisis clinicians who can help people experiencing mental health related distress, thoughts of suicide, mental health, or substance use crisis, or any other kind of emotional distress. You can also call into this line, you know, with concern about a loved one, and seek support that way. In addition to calling, you can text 988 or chat at 988lifeline.org. And 988 began in July 16th of 2022. So previous to that, there was a 10-digit number. But since July 16th of last year, 988 is the Suicide and Crisis Lifeline. And within the state of Vermont, we have 3 Lifeline centers. One's at Northwestern Counseling and Support Services. Another is at Northeast Kingdom Human Services. And then we contract with a local backup center in New Hampshire called Headrest. And since 988's inception in July last year, we've seen quite an increase of call volume and people seeking support through that that call lifeline. Another project that I'm very involved in is the Governor's Challenge, which is coordinated through the Governor's Office, the Vermont Department of Mental Health, and then National Guard. Currently, we have more than 25 representatives participating in the Governor's Challenge. The focus is on service members, veterans, and their families due to the increased risk of suicide amongst that population. The aim is to collaborate, plan, and implement suicide prevention best practices and policies for SMVF statewide. Within the Governor's Challenge, there are three work groups. The first being identifying SMVF and screening for suicide risk, and then promoting connectedness and improving care transitions. And then the last work group is around increasing lethal means safety. So within the state of Vermont, we have work groups that are focused on each of these priority areas and are implementing strategies and on how to address that that priority area within the state of Vermont. And you're more than welcome to ask any questions about various projects that I'm working on as well.
Okay. Yep, keep going. Yeah, you're
okay.
good.
And then I just wanted to talk a little bit about zero suicide, as that's a framework that we're looking at suicide prevention. So I know that there's a lot of text on this screen or on this slide, but just wanted to use it as reference as well. Just looking at what is zero suicide, the program goals are supporting public education and information to improve awareness and access to suicide prevention support and services, developing and supporting suicide prevention infrastructure, policy, stakeholder engagement to improve suicide prevention planning and implementation, and advancing evidence-based and best practices for suicide prevention through workforce development. So ensuring that individuals that are working with people experiencing suicidal thoughts are equipped to work with those individuals. And then also promoting social and emotional wellness to prevent suicides in Vermont. On the right-hand side of this slide, you'll notice a pyramid here, and it outlines the various strategies for prevention, intervention, and then suicide-specific treatment at the top of that pyramid. So it talks a little bit or mentions some of those evidence-based practices that Nick had mentioned earlier as well. With CALM, which is counseling on access to lethal means, and CAMS as well. And then within the state of Vermont, I just wanted to outline the implementation stages of zero suicide within our DA system, so our community mental health agencies. So this planning and reporting survey was administered in December of 2022. And the survey had a response rate of 100%. So all DAs and the two specialized service agencies responded and are currently engaged in zero suicide. And then within each department, it outlines how far along they are in implementing zero suicide within and and kind of where they are in those stages. So if they're fully in place, as you can see, community rehab, rehabilitation treatment services is doing pretty well with implementing zero suicide within that department, as is the emergency crisis services. And then there's other departments that are partially implemented zero suicide, the framework within other departments. And the positive is that there's this continuum across departments have at least begun the implementation of zero suicide. And this is actually, so I'll transition to a little bit of the strategic plan as well, unless there's questions about the slides that I've presented.
No, that's terrific. We're getting crunched for time, so we'll listen to your transition information, and then we'll move to Terry LaValle.
Sounds great. Yeah, so just wanted to speak briefly about the strategic plan. So those three projects that I'm working on or involved in, as am I involved with the Garrett Lee Smith grant and the Comprehensive Suicide Prevention Grant. Those are all integral parts to the strategic plan in terms of looking at the current landscape of Vermont and how we're doing with suicide prevention, identifying any gaps, and then looking at the strategies needed to move the needle on suicide prevention and decreasing suicides within the state and suicide attempts as well. And then looking at the resources that will be needed to fill in any resource gaps or just to move the strategic plan forward. So
thank you. Actually, those comments are very helpful, and it might help us improve the bill going forward.
Yeah. Very well. Happy to answer any questions as they come up.
What I think I'd like to do is to move to Terry first, and then we'll come back, circle back, and see if there are questions overall. Well, thank you.
Yeah, thank you.
Thank you. It sounds like you're doing a lot of good work, and you've been there for such a short time. Sounds like you're making a difference. All of you. I'm thinking of Caitlin and Nick as well. Okay, Terry, go ahead.
Good morning. I want to start by thanking Senator Lyons for allowing me to testify today in the Senate Health and Welfare Committee for listening to this very important topic. I'm Terry Lavely. I am a Northeast Kingdom resident, and for transparency, I always like to share that I have spent 19 years working for a designated agency in the Northeast Kingdom. But today I'm coming with my volunteer hat, testifying for the American Foundation of Suicide Prevention on H481. I found my family with AFSP 7 years ago when I lost my 18-year-old nephew to suicide. And I also attempted to take my own life when I was 15 years old. So this work that I do both personally and through my volunteer work is near and dear to my heart, and I see the importance to it. I just heard, how is this bill going to support us? We have so many grassroots efforts going on in Vermont that we do need this comprehensive plan, Chris's strategic plan, to pull it all together and make sure that we're all on the right paths. I just want to touch on a couple of things. Vermont's suicide rate is 44% higher than the national average. And we have the highest rates of suicide east of the Mississippi. So it is a crisis in Vermont for sure, and especially being such a small state. Men are 3 times more likely to die by suicide than women, and the highest rates of suicide death are in veterans farmers, and construction workers, which Vermont has extremely high populations of all three of those. So we really need to focus our strategic plan around the unique needs of every population and just not put something out there saying, oh, this is what we're doing for everyone. So just honing in on those areas which are very data informed. Like we have the data, we see what's going on, but also supports for schools. I do a lot of work in the schools, and we need to do more of an upstream prevention programs. And it's not just educating our teachers, it's doing a continuum of care where we're educating our students, our parents and caretakers, and our teachers. So it's creating safe communities within our school communities and giving everybody the tools and resources and breaking down the stigma around the conversations of suicide, which is extremely difficult for a kid to reach out to adults they don't feel safe with because they don't know how adults are going to react. So if kids know, like, oh, my teachers and my parents are all getting the same information as I'm getting, it creates safe spaces within school communities, which is where kids spend most of their time, and their teachers and parents and caretakers are the main parts of their lives. So the strategic plan should include all of that, not just focusing on mandating for teachers, but what are we doing to help support parents and caretakers and students to have those conversations. At AFSP, we have a great program called Gizmo's Possum Guide to Mental Health that we start doing in pre-K to 5th grade, where it's not about suicide awareness, it's about what your mental health is and what it feels like to struggle and who you can reach out to help yourself. So that's upstream thinking of starting at an earlier age to get ahead of the curve on that. And the data project that Nick and Caitlin are working on, all of that information is really going to drive the strategic plan of what we do in Vermont. So it's all linked together of how the data is going to inform the decisions we make. I actually, for my professional job, have the pleasure of co-chairing our Zero Suicide team. I've been part of it for many years, and I've already seen the collective impact that we have with Zero Suicide, not only at designated agencies, but reaching out to our community partners, which you would think would be our healthcare providers, but it's really like Council on Aging, Rural Edge, the different components of people that interact with general populations every day, as well as our school systems, and also offering it to the community and making the community a safe place to go. Not everybody works in an industry where they provide case management or interact with marginalized population or vulnerable populations, but we're all human and interacting with each other every day. So the skills that we're implementing through the Zero Suicide process are for everyone. It's for you and your family too. So you know how to have the conversation, and then you know what to do and how to get people to help. We also know that 60% of people that die by, over 60% that die by suicide visit some kind of healthcare provider 30 days prior to their death. But that healthcare provider is not always mental health. Less than a third are actually enrolled in a mental health system. So making sure that our primary care and our emergency departments have the tools, the evidence-based practice for the Columbia Suicide Severity Rating Scale, knowing how to ask the question, knowing how to do, we heard a lot about the Counseling on Access to Lethal Means training, CALM training, and making sure that all of our community partners have those trainings so we can put time and space between the crisis and the access to means. And that time and space is really what saves lives, opening the conversation. How can we support you? And putting some time and space between your thoughts and your plan so we can get you to the help that you need. And the help isn't always mental health professionals. We forget sometimes that people's drivers to thoughts of suicide could be housing, could be food insecurities, could be financial insecurities. So oftentimes we feel that people that struggle with suicidal thoughts, they have a mental health condition, but that's not always accurate. And most times it's other stressors in their life that's impacting their mental health. So wrapping the continuum of care around making sure we're a well-resourced state around all of the areas that impact mental health, not just mental health services. And lastly, I can't say enough about post-vention services. As an attempt survivor and a loss survivor, the American Foundation for Suicide Prevention has saved my life. It has given me a sense of purpose. It's National Volunteer Month. I don't know if you guys know that, and I spend a lot of time volunteering. So I'm proud to be here volunteering to do this, but those post-vention services are really prevention too. Individuals that experience a suicidal loss are 3 times more likely to have thoughts of suicide. So really making sure that we have great supports for family and loved ones that lose someone to suicide and get them well connected within the systems. My nephew died 7 years ago, and I still grieve just as deeply today as I did 7 years ago. And I know that's hard to believe. You think, once the loss has happened and the time has gone by, I still ugly cry, when I think about him. I'm proud to do this work, but this is hard work. And what I do both personally and through my volunteer work has given me a sense of healing, of being able to advocate for others that might not have the voice to share the information that I can share, and lean in hard to these conversations of anti-stigma, supporting our kids in school, looking at, trauma-informed care for our veterans, our farmers, our construction workers, and how each population needs specialized supports, trainings, and resources. It can't just be a one-size-fits-all solution. And that's what this bill is essentially saying, is comprehensive to meet the needs of Vermonters, not just, we're putting a blanket thing out there. We're looking at the statistics, we're looking at the data, and we're developing plans to support all Vermonters. So I know you're running low on time, and I just rattled off a ton of information. So I will pause and allow for questions and anything you guys would like to ask.
Thank you so much. And if you could send us, I don't see your testimony on our webpage. It would be very helpful to have it in writing, because it underlies a lot of the issues that we're hearing about. So we appreciate that very much. So Senator Hardy has a question. I think there was a question earlier for Chris, and we'll go back to that as well. So go ahead, and then we'll just take about 4 or 5 more minutes.
Great, thanks, Madam Chair. And Terry, thank you so much for your testimony. I think you answered the question I asked earlier about the bill and what the point of the bill is. So I appreciate that that helped me make sure it wasn't just a feel-good bill, which we are prone to do sometimes. But my question is for sort of all of you on the screen. You mentioned the 3 populations: construction workers, veterans, farmers, and then also there was obviously some focus on youth, which I appreciate all of those. But one population I didn't hear about, and I'm wondering if there are statistics or efforts that are focused on new Americans or refugee immigrant populations in our state, or people who English is not their first language, or sort of broadly speaking, are there efforts to reach those populations and specifically doing some, making sure that your work is accessible in multiple languages, and doing outreach to hard to reach communities in that area? I wonder if anyone's focusing on that.
Yeah, I'm happy to mention it's a great question, and it's important that we include a focus on a number of those populations. And we do. It was kind of buried in the one of my slides, but for youth and youth who identify as Black, Indigenous, or as youth of color, as well as youth associated with families who are new Americans, or have who don't speak English as their first language. We do have some earmarked funding to specifically do work with youth from those communities. We haven't come up with a specific plan exactly what that's going to look like, but our overall focus is to support activities that promote connectedness and just mental health promotion among youth. And unfortunately, it's a small amount of the grant in terms of funding. So it's not something we're going to be doing statewide, but we will be piloting it in several different regions, and hope that the results of that pilot will give us more information about what else we need to be doing for youth among those various populations. And then the Department of Health, you may be aware, has a very large health disparities grant that it received from the Centers for Disease Control that's not specific to mental health or suicide prevention, but as part of that large grant, we actually were able to set aside some funding to pilot suicide prevention as well as overdose prevention and mental health and substance use support for various populations that were experiencing mental health or substance use disparities. And we're going to be funding 5 different pilots through that grant. And I would say, I think all 5 of them are either focused on, or include, Black, Indigenous, or people of color as one of their focus populations. We have one pilot that's specifically working with the United States Committee on Resettlement and Immigration. I'm probably not saying that correctly, but it's USCRI. They're doing work with a couple different refugee communities, including people from Afghanistan. So one of the pilots is actually going to be working specifically with them on expanding access to mental health and substance use support. So actually those are just getting started, but happy to share more information about that once those get going.
Okay, and thank you. Maybe this is something we might consider putting in the bill. Just, I think a broader focus or more intentional focus, because I think I know being new to Vermont, regardless of your circumstances, is hard for a variety of reasons, but especially if you're here and you don't speak the language or the culture is radically different. And so a focus intergenerationally on new Americans in Vermont, or refugees, immigrants, and people who don't speak English as a first language in Vermont is really helpful, because those communities and populations often have really unique circumstances that, and also talking about suicide and mental health may be more challenging, or you need a different approach. So I think having a specific plan in place rather than just a couple random pilots, or random isn't the right word, but you know what I mean? So that would be a good thing to have in your strategic plan, Chris or Nick.
So you're pointing out some things that we can add into the bill, and I've written some down as well. So what we'll do is we'll come back to this bill and have a discussion about how we might want to improve it based on the testimony that we've heard here today. And so we'll keep you informed about when we're doing that, so you can help us. And I'm gonna close the discussion on the bill for now, because we need to move on. But I greatly appreciate each one of your being here this morning. Thank you. This has been terrific. It will launch us in a new way toward public health prevention of suicide in our state. And I appreciate all the work that you're doing. Thank you. Okay, this is good.
Thank you, everyone.
Thanks, everybody. Have a great day.
And so we're going to move on to H89, a little proposal amendment. I'm thinking this shouldn't take us more than 5 or 10 minutes. And then we're also going to be doing H473, and we hopefully will be done by 11:30.
Okay.
I think you'll be. I
can hold
it.
I'm not sure I can.
I had the luxury of going out for some time, and you didn't.
I just need to go across the hall, but
Wait.
Okay, well, we're going to go to Jen.
Okay, you don't want OPR?
Love to have OPR. When are they joining us?
5 minutes.
Okay, well.
then we can have a 5-minute break.
I need to be upstairs at 11:30. So, okay, so we'll take a